introduce Bernard Iung to present another ESC guideline which has been updated in 2015, and that is the one on infective endocarditis, again a medical condition which is important for many specialties and also associated with important comorbidities. Bernard?
Thank you, Stefan. Dear colleagues, I thank the organizer for giving me the opportunity to be part of this session and to meet friends with whom I was involved in guidelines, task forces, and also to share experience with our Swiss colleagues. Here are my disclosure. With regards to endocarditis, there have been important changes in epidemiology over the last years, as illustrated by this nationwide survey in France, showing that endocarditis now affects mainly elderly people, and that the microbiological profile has changed with a predominance of staphylococcal endocarditis at the present time. Endocarditis remains a rare disease that is approximately 1,500 and between 1,500 and 2,000 cases per year in France. However, a disturbing finding is that in-hospital mortality remains very high, and of course, this justifies any attempt to prevent this disease. These changes highlight the need to have updated guidelines in this field, and I will begin with the prevention of endocarditis because it concerns a number of practitioners, not only those who take care of patients with acute endocarditis. Up to the years 2000, there has been a constant increase in the indication of antibiotic prophylaxis in infective endocarditis, leading to recommend antibiotics before all types of invasive procedure in any patient at risk for endocarditis. The first downgrading of indication for antibiotic prophylaxis came in 2002 from a French consensus which recommended antibiotic prophylaxis only in an optional manner in intermediate risk patients. This was the consequence of concerns relating to the pathophysiology of endocarditis. Previously, the role of high-grade bacteremia was put forward, and of course, it was logical to prescribe antibiotic prophylaxis to avoid bacteremia in such cases which occur during any invasive procedure. However, with time we learned that there are also a number of everyday life bacteremia which may occur during chewing or toothbrushing, and they are characterized by lower grade bacteremia, but which are much more repeated over time. Are they really harmful, and may these low-grade bacteremia cause endocarditis? It is a crucial question because, of course, these low-grade bacteremia are not amenable to antibiotic prophylaxis. There are arguments supporting their harmful role, and one of them comes from this animal model from the team of Philippe Morayon in this country, which compared high-grade bacteremia, mimicking bacteremia after invasive procedure, and low-grade bacteremia. Endocarditis in this animal model occur in all animals after high-grade bacteremia, but also in 70% of those who were exposed to continuous infusion of low-grade bacteremia. Of course, we would wish to have clinical data in humans. This is particularly difficult given the rarity of endocarditis, and we can only proceed with extrapolation from different estimation. One of these was done by my friend Xavier Duval in our institution, who used a previous French survey to estimate the numerator of incidence of endocarditis, that is a number of cases occurring after dental care, and also the denominator, that is the number of dental care in patient at risk from national databases. And this estimation came to the fact that after protected procedure, that is procedure performed after antibiotic prophylaxis, the risk of endocarditis was 1 on 150,000 cases, while after unprotected procedure, without antibiotics, it is roughly 1 out of 50,000. It does not mean that antibiotics prophylaxis is not useful, because it reduces the risk. However, the absolute risk remains very low, even if it's markedly different between native and prosthetic endocarditis. And this low risk should be put in balance with the possible harmful effects of antibiotic prophylaxis prescribed in a large number of patients. If we use these estimations and based on the risk of 20% in hospital mortality, we estimate 1 death per 250,000 procedures without antibiotic prophylaxis. And if we combine this with without antibiotic prophylaxis, and if we combine this with the risk of severe harmful effects of antibiotic prophylaxis, the risk-benefit analysis does not support a wide use of antibiotic prophylaxis, at least in intermediate risk patients. If we now estimate the risk in high-risk patients, that is, patient with valve prosthesis, previous endocarditis, or congenital heart disease, based on the previously mentioned estimations, the risk of endocarditis after unprotected procedure is higher, and in this case, the risk-benefit analysis would rather support the use of antibiotic prophylaxis. Of course, these are only estimations, but we should proceed with the data that we have. And these concerns were further adopted by other countries, first the UK, then the US, as there was a progressive downgrading on the indication of antibiotic prophylaxis, and the ESC adopted the same recommendations than the US guidelines, that is to restrict antibiotic prophylaxis to certain dental procedures only in patients at high risk for endocarditis. We did not choose to go as far as our British colleagues from the NICE, who withdrew any indication for antibiotic prophylaxis. These are the last guidelines in 2015, and there were not changes as compared with the previous version in 2009 as regards indication for antibiotic prophylaxis. It should be considered only in patients at high risk of endocarditis, patient with any prosthetic valve, including transcatheter valve, patient with previous endocarditis, patient with cyanotic congenital heart disease, or congenital disease repaired with prosthetic material for the first 6 months. Conversely, antibiotic prophylaxis is no longer recommended for other valvular or congenital heart disease. What are the procedures for which antibiotic prophylaxis is recommended? Mainly dental procedure, which consist in manipulation of the gingival or periapical region of the teeth or perforation of the mucosa. It is not recommended, antibiotic prophylaxis is no longer recommended for other dental or other invasive procedures. The modalities have not changed either. This is still 2 grams of amoxicillin 1 hour before the intervention, or clindamycin if there is allergy. This table is probably one of the most important of the chapter on prevention. There has been a constant downgrading in the indication of antibiotic prophylaxis, but this does not mean that there is a decrease of indication of any prophylaxis. And non-specific prevention measures are probably more effective than antibiotic prophylaxis. These are recommendation which should ideally apply to the general population, but of course they should be highlighted and strengthened in patient at risk, in patient at high risk of endocarditis, but also in those at intermediate risk. And that includes strict dental hygiene and dental follow-up. And this is of utmost importance for limiting these low-grade everyday bacteremia, which are harmful and are not amenable to antibiotics, disinfection of wounds, eradication of chronic carriage, of course, curative antibiotics, avoiding self-medication, and also, which is of utmost importance, particular care during any medical intervention and any medical care for medical team and also paramedics, given the increased incidence of staphylococcal endocarditis, which is mainly attributed to healthcare endocarditis. Do we have any data regarding the impact of these changes, of this restriction in the indication of antibiotic prophylaxis? We have some. Some are derived from the 3 French surveys, and after the downgrading of indication of antibiotic prophylaxis in 2002, there was no increase in the incidence of infective endocarditis, and more importantly, there was no increase in the incidence of endocarditis due to oral streptococci, which are targeted by antibiotic prophylaxis. Conversely, there was an increase in staphylococcal endocarditis, in particular in patients without previously known heart disease. We have also data from the US suggesting that there has not been any increase in the number of cases after the restriction of antibiotic prophylaxis in US guidelines in 2007. However, we have some disturbing finding coming from the UK more than 1 year ago. Is in this survey, the authors were able to document a strong decrease in the prescription of single-dose antibiotic treatment, which corresponds to antibiotic prophylaxis, following the NICE guidelines in 2008. They also demonstrated an increase in the incidence of infective endocarditis, and there was a significant difference in the slope of the increase in incidence following the NICE guidelines in 2008. Was there a causal relationship? The authors were cautious and they concluded to a temporal relationship, but not to a causal relationship, because there may be a number of confounding factors. And in addition, even the temporal relationship may be subject to concerns. We did not have the data, but we digitized the curves published in the paper, and during the same analysis, the same statistical analysis of time series, we found that the testing for slope change was statistically significant for any time point between 2003 and 2010. So it is not straightforward to think that this increased incidence corresponds to the year 2008. Some disturbing findings again coming from the US last year, showing once again an increase in the incidence of endocarditis, but with a significant slope change for streptococcal endocarditis, which is a type of endocarditis targeted by prophylaxis. However, other surveys performed in other large administrative databases in the US found contrasting findings. In the Medicare database, there was no increase in the incidence of endocarditis, and in the same analysis of the same database performed by another team, there was no increase in the number of cases. So these discrepancies shows that we should be cautious with the interpretation of such data derived from large administrative databases. Finally, a recent finding from a Canadian database showed once again an increase in the incidence of endocarditis, but this was due mainly to staphylococcal endocarditis, and there was a decrease in streptococcal endocarditis. What about the diagnosis of endocarditis? We all know as clinicians that it is a difficult diagnosis since it combines a lot of features which are not individually specific. Of course, echocardiography remains a cornerstone of the diagnostic of infective endocarditis, and transesophageal echocardiography is mandatory in almost all cases. Just a word of caution, when there is a negative initial TTE and a low clinical suspicion, it is more appropriate to repeat echocardiography rather than performing immediate transesophageal echo. A major innovation in the 2015 guidelines in the introduction of non-echocardiographic imaging in the diagnosis of the involvement of endocardium. The introduction concerns, in particular, nuclear medicine techniques and also CT scan, in particular for the diagnosis of perivalvular abscesses. Another innovation is the introduction of imaging to detect silent embolic events, which are now introduced as a minor criteria in a modified Duke classification. This modified classification leads to this algorithm, which is useful in clinical practice. Of course, nuclear techniques are not recommended if there is already a diagnosis of definite endocarditis using the usual Duke criteria, also if it's rejected with a low clinical suspicion. But in the difficult cases of patients with possible or rejected infective endocarditis according to the initial Duke classification, but with a high clinical suspicion, we may use PET scan and CT scan or MRI with different hierarchy according to whether it is a native or prosthetic valve endocarditis. And these new imaging techniques may lead to decrease the number of cases which will be classified only as possible infective endocarditis. We should not forget the importance of microbiological criteria in the diagnosis of endocarditis. This is the other major criteria in the Duke classification. And in this field, too, there have been important improvements, in particular in rapid diagnosis. And in the near future, the use of blood PCR is likely to further reduce the number of endocarditis without identified microorganism. Just to end with this rapid overview of recommendation, a brief look on the complication of endocarditis and the inherent indication for surgery during the acute phase. We know that the three main complications of endocarditis are hemodynamic, thromboembolic, and infectious, and they account for the high mortality we previously underlined. If we look at heart failure, in the large ICE cohort, it affected as many as 33% of patients, as a majority being in NYHA class 3 or 4. It is associated with a much higher mortality, 30% in patients with heart failure, and this mortality was decreased in patients who were operated on. Of course, there may be confounding factors because operated and non-operated patients differ by other features, other characteristics. However, we have strong arguments supporting the fact that early surgery is mandatory when there is heart failure due to valvular lesions. With regards to thromboembolic events, we have learned that they are much more frequently diagnosed when using systematic imaging. Silent embolism are frequent, in particular when using MRI, which has a high sensitivity, and to detect embolic events, in particular cerebral embolism, which are the most frequent in location and which, of course, may have dramatic sequelae. This embolic risk may be evaluated at the beginning of the management of patients with endocarditis, thanks to this scoring system proposed by the team of Gilbert Habib in Marseille. And this is of utmost importance because most embolic events occur at the very beginning of antibiotic therapy. So if we think that the patient has a high risk of embolism, we should consider surgery rapidly. Infectious complications are more rare. They are favored by the virulence of microorganisms, and the main consequence is the extension of perivalvular lesions, which may be associated with further complication, conduction disorder in particular. They increase the complexity of surgery, the operative mortality, and the risk of later interventions. Based on these different complications, hemodynamic, embolic, and infectious, this table summarizes indication for surgery in left-sided infective endocarditis, whether it is on native or prosthetic valve. And we know that surgery is strongly recommended in any kind of heart failure in case of uncontrolled infection and also in case of large vegetation with previous embolic events. These particular features of these recommendations is also to give advice on the timing of surgery, which is particularly important in practice. How are these guidelines applied? There may be some concerns. We use the previously mentioned data of the French survey in more than 300 patients with native valve endocarditis. As many as 73% of these patients has a theoretical indication of surgery according to guidelines, but surgery was not performed in a number of these cases. In certain cases, indication was recognized and it was stated that patients were at too high risk for surgery, but it is disturbing to notice that in 16% of the cases, indication was not recognized, and there was probably a confusion between indication of surgery and the risk of surgery. So to conclude, this recent ESC guideline recommend continuing antibiotic prophylaxis in high-risk patients undergoing the highest risk dental procedure. We didn't choose to go as far as the NICE guidelines in the UK, but we also underline the importance of oral and cutaneous hygiene, which are probably at least as effective as antibiotic prophylaxis. And non-specific infection control measures are mandatory due to increasing number of staphylococcal endocarditis. The incorporation of multimodality imaging besides echocardiography is probably one of the most important achievements of these recent guidelines. Indications for surgery are based on the most frequent complication of infective endocarditis, and it is important to diagnose them at a very early stage to allow for timely surgery. And finally, specific surveys are needed to better ascertain the implementation of guidelines. And there is a good news. This registry will begin in the following months under the auspices of the EORP structure of the ESC. Thank you for your attention.